Hi my dear students, I'm Dr. Jeetu. Today we'll be dealing with an important chapter, patterns of bone loss and trauma from occlusion. For most part I have referred Karansa's 13th edition. I'm sure most of you have Karansa's 13th edition book or at least the soft copies with you. So please do refer along with the class going into the presentation. So this is a figure from Karansa. This figure depicts pathways of inflammation. So what is the normal pathway of spread of inflammation? First, inflammation affects our gingiva. Then from gingiva, the inflammation passes on to the alveolar bone. You can see the arrow mark 2. From the alveolar bone, it spreads into the periodontal ligament. That is arrow mark 3. So this is the normal pathway of spread of inflammation. As we already mentioned, the inflammation starts at the gingiva and this inflammation destroys the gingival and the transeptal fibers. We know transeptal fibers are common to gingiva as well as periodontal ligament. There is a continuous tendency to recreate the transeptal fibers across the crest of the interdental septum. So this is a specialty of the transeptal fibers. There is a continuous tendency to recreate these fibers even if it is destroyed due to inflammation. So if someone asks you which are the group of fibers that is present even in case of extreme periodontal disease, it is transeptal group of fibers. Coming to another concept, the radius of action. So Garand and Chow were the authors who gave the concept of radius of action. Radius of action means when a bacteria releases some endotoxins, there is a distance or there is a radius around which this endotoxin can induce bone loss. So Page and Schroeder were the people who gave a value for this radius of action. They said there is a range of effectiveness of about 1.5 to 2.5 millimeters around a bacterial biofilm which can induce bone loss. Now, when this bone loss happens, there is a rate of bone loss. It was given by Lowe based on his study on Sri Lankan tea workers. So, there were three group of people showing three different rates of progression of bone loss. In 8% of the population, there was rapid progression of periodontal disease. That is 0.1 millimeter to 1 millimeter per year they found bone loss. In 81% of the population, that is in majority of the population, there was moderate progression of periodontal disease. There was a loss of 0.05 to 0.5 millimeters of bone in a year. In 11% of the population, there was minimal or there was no progression of disease at all. That is 0.05 to 0.09 millimeter was their annual bone loss rate. So in 8% it was 0.1 to 1 millimeter, in 81% it was 0.05 to 0.5 and in 11% it was 0.05 to 0.09. Now I'll tell you about another concept, that is bone factor concept, which was given by Glickman. In this concept, he considers a systemic regulatory influence in case of all periodontal disease. So Glickman believed that there is no pure case of periodontal disease alone. There is always a systemic regulatory component. This is called the bone factor concept. Now, periodontal bone loss may occur with generalized skeletal disturbance like hyperparathyroidism, leukemia, histiocytosis X, etc. by mechanisms that are unrelated to biofilm. So, like Glickman proposed, there are periodontal bone loss happening with a variety of systemic skeletal diseases. But this is not the only reason for periodontal bone loss, or there need not be a systemic regulatory influence in case of all periodontal disease. Now we discussed some points about bone loss. Now there are some patterns of bone loss. There are 11 patterns of bone loss described in Karansa. 1 is fenestration, 2 is dehiscence, 3 is horizontal bone loss, 4 is vertical bone loss or angular bone loss, 5 is crater, 6 is bulbous bony contour, 7th one is reversed architecture, 8th one is irregular bony contours, 9 is exostosis, 10 is buttressing bone formation and 11 is furcation bone loss. Coming to the first pattern, that is fenestration. Fenestration, as we all know, it is a oval shaped or a window like bone loss over a root prominence. This is not continuous with the marginal bone. So the marginal bone is intact and there is a bone loss which is a window like bone loss over the root surface. So it happens usually on labially placed tooth which has thin bony plate over it and usually the root is prominent. So this results in a bone loss. Be clear with the figures also. Fenestration will always look like a oval shaped window. Coming to dehiscence. Dehiscence is a fenestration, but it extends to the marginal bone. So it is continuous with the marginal bone. From the marginal bone, it has lost apically along the root surface. This also happens in labially positioned tooth, and it is considered as a most common type of bone loss. Commonly occurs in the anterior teeth. Then we have horizontal bone loss. Horizontal bone loss is said to be a type of bone loss when the level of the bone on two adjacent tooth are at the same levels. So you can draw a horizontal or a straight line connecting these two teeth along the bone level. Vertical or angular bone loss means the bone level on one tooth surface is apical to the level when compared to the other tooth surface. So it looks angular. It is not a straight horizontal line. It is a more or less vertical line. Now vertical bone loss can again be classified into three. It is 3-walled, 2-walled or 1-walled depending upon the number of bone walls remaining. That is very important. It is not the number of bone walls lost. It is the number of walls remaining. So 3-walled means 3 walls are remaining for that. 2-walled means 2 walls are remaining. And 1-walled means only 1 wall is remaining. So 3-walled is a bone loss with a good prognosis because 3 walls are there, and 1 wall is the worst lesion because only 1 wall is remaining. All the other 3 walls have been lost. The next one is exostosis. Exostosis are outgrowths of the bone of varied size and shapes. It is just an overgrowth of the bone of different size and shape. It can be small nodules, large nodules, sharp ridges, spike-like projections, or a combination of any of these. The next one is buttressing bone formation. Buttressing bone formation occurs in an attempt to buttress the bony trabeculae, which is weakened by resorption. That is, when some dehiscence or some bone loss occurs, the body attempts to strengthen the bone. That is, already the height of the bone has been reduced. So body wants to strengthen the bone, buttress the bone by increasing its thickness. This is called buttressing bone formation. It is of two types, central and peripheral. Central, when the bone formation occurs in the central compartment, and peripheral, when it happens over the bone surface or peripherally. This peripheral buttressing bone formation has another name that is known as lipping. This is also an important question. Peripheral buttressing bone formation is also known as lipping. Another pattern that we mentioned was craters. So osseous craters are actually specific type of 2-walled defects, and they present as concavities at the crest of the interdental bone. It is confined within the facial and lingual walls. So it is clear from the figure, the facial and the lingual wall is present, and there is a concavity in between this facial and the lingual walls. Craters have been found to make up about 1/3 of all the defects. So it is pretty common. 1/3 of all bone defects are craters, and about 2/3 of all the mandibular defects are craters. So it is very common in mandible. Now we discussed fenestration, where the bone loss is not continuous with the marginal bone. Dehiscence, where the defect is continuous with the marginal bone. Horizontal bone loss, vertical bone loss. Types of vertical bone loss being 3-walled, 2-walled and 1-walled, and craters also we discussed. We also discussed exostosis and buttressing bone formation. Coming to bulbous bony contours, they are bony enlargements that are caused by exostosis, adaptation to function, or buttressing bone formation. So it is a generalized, the contour of the bone is bulbous. It can be due to exostosis. We already mentioned exostosis can be small nodules, large nodules, spikes, or any combination of these. Or this bulbous contour can also be due to an adaptation to function or a buttressing bone formation. This bulbous contour is more frequently found in maxilla. The next pattern is negative architecture. So we will discuss what is negative, what is positive, and what is flat architecture. In negative architecture, there is loss of interdental bone without a loss of radicular bone. So the first figure is positive architecture, wherein the radicular bone is apical to the level of the interradicular or interdental bone. In negative architecture, because of the loss of the radicular or the interradicular or the interdental bone, it is at a more apical level compared to the radicular bone. In flat architecture, both are at the same level. So the negative architecture is most common in maxilla of the patients. Another pattern is ledge. Ledges are plateau-like bone margins that are caused by resorption of the thickened bony plates. So we already mentioned due to buttressing bone formation or something, the bony plates get thickened. When there occurs resorption of this thickened bony plates, it will look like a plateau. So this is known as a ledge. And the last one is furcation involvement. It refers to the invasion of the bifurcation or trifurcation of a multi-rooted teeth by periodontitis. So when bone loss occurs in the furcation area, it is known as furcation involvement. And the probe used to detect furcation involvement is Neighbors probe. This is also an important question. Neighbors probe is used to detect furcation involvement. So we discussed a lot of patterns of bone loss. By far, the horizontal bone loss is the most common pattern of bone loss in periodontal disease. There is even destruction of the bone. The next term is continuous defect and combined defect. What is the difference? Continuous defect involves more than one surface of a tooth in a shape that is similar to a trough. It is also known as a circumferential defect. So when the bone defect involves more than one surface of the tooth, if the bone loss starts from the buccal surface and it moves on to the mesial surface, it is known as a continuous defect, or it is trough-like, and it can also be called a circumferential defect along the circumference of the tooth. The next one is the combined osseous defect. That is, the number of bony walls in the apical portion of the defect is greater than the number in the occlusal portion. Here it is known as a combined defect. That is, it can be a combination of a 2-walled and a 3-walled lesion. And the number of the walls when you move to the apical portion is always greater. This is known as a combined defect. With that, we finished patterns of bone loss. Coming to trauma from occlusion. Trauma from occlusion, the term was coined by Glickman. According to 2017 World Workshop of Periodontology or WWP classification, that is the recentmost classification, trauma from occlusion has been renamed as occlusal trauma. So there is no more trauma from occlusion, it is occlusal trauma. So one classification of trauma from occlusion is acute trauma from occlusion and chronic trauma from occlusion. Acute refers to periodontal changes associated with an abrupt occlusal impact, such as due to biting on a hard object. When you suddenly bite a stone, what will happen is an acute trauma from occlusion. Chronic trauma from occlusion refers to periodontal changes associated with gradual change in occlusion. So gradually, when there is any change in occlusion, it can be due to a habitual change in bite of the patient or something. When this occurs over a period of time, or it turns out to be chronic, it is known as a chronic trauma from occlusion. Another classification is primary and secondary trauma from occlusion. This is also very important. Primary trauma from occlusion means when the trauma from occlusion is the result of alteration in occlusal forces. Primarily, the trauma is from occlusion itself. Okay, so trauma from occlusion is primarily due to alteration in occlusal forces. This is called primary trauma from occlusion. So the periodontium of the patient is healthy. The defect is due to occlusal forces. And secondary trauma from occlusion is when there is reduced ability of the periodontium, or the periodontium is not healthy to resist the occlusal forces. In this case, the occlusal forces can be normal, or the occlusal forces can be altered also, but anyway, the primary defect is a reduced ability of the periodontium. In this case, it is known as secondary trauma from occlusion. Whichever be the type of trauma from occlusion, the tissue response occurs in 3 stages. 1 is injury, 2 is repair, and 3 is adaptive remodeling of the periodontium. So first, an injury happens to the periodontium, then the second stage is repairing it, and the third stage is remodeling of the periodontium. Trauma from occlusion occurs in supporting tissues, and gingival blood flow is not affected. This is a very important point. Gingiva is not affected in trauma from occlusion. So there is no pocket formation also. Mobility is a feature of trauma from occlusion, and the mobile teeth in humans harbor significantly more number of Campylobacter rectus and Peptostreptococcus micros. So you may get this question: which are the microorganisms associated with mobile teeth? It is C. rectus and P. micros. Now shall we discuss the radiographic features of trauma from occlusion? There is increased width of the periodontal space and often with thickening of the lamina dura. As we already know, there is trauma from occlusion means there is abnormal occlusal forces. Because of this, there is increased width of the periodontal space and thickening of the lamina dura. A vertical rather than horizontal destruction of the interdental septum. There is vertical bone loss happening in trauma from occlusion. Radiolucency and condensation of the alveolar bone. Because of this bone loss, there is radiolucency and condensation of the alveolar bone. And we can also see root resorption. Another important point is when the trauma from occlusion is eliminated and substantial reversal of this bone loss occurs except in presence of periodontitis. If the person is not suffering from periodontitis and he has trauma from occlusion and a bone loss due to this trauma from occlusion, once you relieve this trauma from occlusion or this traumatic occlusion, you are going to see a bone fill. There is a reversal of bone loss occurring. So this may be asked as like true or false statement. Also suddenly it can be confusing for us. Can the lost bone be reformed without be doing anything? Just by reversing the trauma from occlusion, will bone fill occur? Yes, it can occur. There is reversal of bone loss because of elimination of trauma from occlusion. Next, coming to hypofunction. So it is like opposite to the trauma from occlusion. In hypofunction, there is insufficient stimulation of the periodontal ligament. This causes thinning of the periodontal ligament, atrophy of the ligament fibers, osteoporosis, and there is a reduction in alveolar bone height. Now we'll discuss another important concept, that is pathologic migration. The drifting usually occurs in a mesial direction. We all know this. When the tooth is erupting also, the eruptive force is mostly in a mesial direction. When there is a missing 6, you have seen the 7 extruding and mesially migrating into the space. But the premolars frequently drift distally, right? The second and the third molars tilt mesially, and this also results in a decrease in the vertical dimension. One more important point is the mandibular incisors direction of drift. It is usually lingual. So the general idea for us is migration or drifting in a mesial direction, but for premolars it is frequently distal, and for the mandibular incisors it is frequently lingual. Because of this lingual drift of the mandibular incisors, anterior overbite is increased and mandibular incisors will strike the maxillary incisors near the gingiva, and there is trauma to the gingiva, and due to this the maxillary incisors will be pushed labially and laterally, right? We have all encountered this situation. Look at the figure. Many periodontally affected patients come to us with this appearance. Why this happens? As we already mentioned, the mandibular incisors tilt lingually and the maxillary incisors will be pushed labially and laterally, and there is no contact, and the anterior teeth will extrude because there is no incisal apposition at all, and this also lead to a diastema creation due to the separation of the anterior teeth. So the anterior teeth will extrude because the incisal apposition has largely disappeared. We already mentioned mandibular incisors will tilt lingually, maxillary incisors will be pushed labially and laterally, so there is no incisal apposition at all. Because of this, anterior teeth will extrude and diastemata are created due to the separation of the anterior teeth. There are other reasons for pathologic migration or movement of this teeth. It can be pressure from the tongue. Because of pressure from the tongue also the tooth is going to move, and also because of pressure from the granulation tissue in the periodontal pocket also tooth can migrate. Now coming to the most important portion, the trauma from occlusion has two schools of thought. It was given by Glickman and Verhoek. So what is the school of thought of Glickman about trauma from occlusion? He says the gingival lesion in the zone of irritation will spread directly into the trauma exposed periodontal ligament, and it is not via the bone. Remember the very first slide we were discussing about the normal pathway of spread of inflammation, wherein it was from gingiva to the alveolar bone and from the alveolar bone to the periodontal ligament. According to Glickman, there are two zones, zone of irritation and zone of co-destruction. Zone of irritation is the marginal gingiva, and zone of co-destruction is the periodontal ligament fibers plus the alveolar bone. So he says the gingival lesion in the zone of irritation will spread directly into the periodontal ligament in case of trauma from occlusion, and then it spreads to the bone, and this causes alveolar bone loss. This was the line of thought of Glickman to support trauma from occlusion. According to Verhoek, it is not due to trauma from occlusion the angular bone loss is happening. He says angular defects and intra-bony pockets occur equally in teeth with and without TFO. So he studied many teeth with TFO and without TFO, and he found that angular bone loss were present in both the teeth. So he attributed subgingival plaque as the factor causing vertical bone loss. According to Glickman, trauma from occlusion was the predominant cause of angular or vertical bone loss. According to Verhoek, trauma from occlusion is not doing anything much. Subgingival plaque is the culprit. When the subgingival plaque of one tooth has reached a more apical level than the plaque on the neighboring teeth, then definitely the volume of the alveolar bone surrounding the root will also be comparatively large difference will be there. So in case of narrow interdental bone, because of the radius of the action is 1.5 to 2.5 millimeters, it can destroy this all this bone. So it becomes a horizontal bone loss. When the interdental bone is wide, or it is wider than this 2.5 millimeters, bone will not be lost uniformly. It will be lost to a more apical level in one side. So it creates a vertical bone loss. So according to Verhoek, it is subgingival plaque, and then the subgingival plaque on one tooth is more apical and the width of the interdental bone is large. It is going to create a vertical bone loss, and trauma from occlusion is not creating this vertical bone loss. So I hope you are clear with the Glickman's concept and Verhoek's concept. Glickman was the one who said trauma from occlusion is the culprit for causing vertical bone loss, and Verhoek said no, trauma from occlusion has nothing to do with this, it is subgingival plaque. Now coming to diagnosis. Patient will complain of tired jaws because of the traumatic occlusion. His jaws will feel tired, and there is a clinical feature of mobility. We can find mobile teeth. Radiographic features, all of the radiographic features which we discussed earlier will be present, and the clinical diagnostic test is Fremitus test. Fremitus test is you place your wetted finger on the gingiva and ask the patient to bite. When trauma from occlusion is present, it creates a vibration in the tooth root which will be transmitted to the gingiva, and your finger can feel this Fremitus or vibration. So the clinical diagnostic test for TFO is Fremitus test. Coming to the last slide, TFO in implants, we have done the composite beam analysis, and we found the modulus of elasticity of titanium is 5 to 10 times more than the cortical bone. And when there is a stress concentration occurring due to trauma from occlusion, the concentration of the stress occurs where the material first comes in contact, where the implant first comes in contact is the alveolar bone crest, right? So the alveolar bone crest is going to get affected. Because of this, it is going to be lost. The alveolar crest is the portion which will be lost first. So I hope it is clear for you the patterns of bone loss as well as the trauma from occlusion and its concepts. If you have any doubt, feel free to contact me. Thank you.